So we've kind of talked about this so far. It's painful. I warned you up front, it was painful. If you want real excitement,
Read the book.
read the book. This chapter's a rough chapter. That's chapter 2. Okay. This is chapter 3 we're going to be starting into. And this is where I'm going to focus more of the exam on, is Module G as opposed to Module F.
You mean quiz?
Quiz, yeah. Okay, so that's where we're at now.
Do you mean chapter 4 or chapter 2?
It's chapter 3. They dropped the chapter.
Oh, so chapter 3 included?
It's chapter 3 in Pelbeam. Because this is terminology that we have to get down clean. Okay. So, we only can control one thing at a time. Even though ventilators say, oh, it's dual control. It's not. You can't do two things at once. Even people who think they're multitasking really aren't. You only do one thing at a time. So when we're controlling a variable, we're either going to be controlling pressure, volume, time, or flow. Everything that we're not controlling can become a variable at that point. So we're going to call different types of breaths from the machine as being generated by a pressure controller, a volume controller, a time controller, or a flow controller. Who's in charge?
We are.
Well, no, but which are you making in charge? With pressure controllers, a pressure control breath, this is what we've been talking about as being a pressure-oriented breath. Pressure.
You're going to give 20 centimeters of water.
Yes. Pressure remains constant regardless of changes in compliance and resistance. I don't care what you do to compliance, that 20 centimeters of water never varies. Within reason.
What?
Well, if somebody coughs against it, it's not the ventilator generating excess pressure. We're assuming we have a passive patient lying on the opposite side. Okay? It's the left side of the equation of motion, that pressure component. Because I'm controlling the pressure, then flow and volume become variable. Okay? Technically, we can do positive or negative pressure. Since we don't see iron lungs rolling around our ICUs that often, we'll just say that they're possibly there. I ran across a great video, by the way. I'm going to try to post it, send you an email with it. Woman talking about her life. I forget for how long in an iron lung. And I was like, yeah, very, very touching story. So we okay on pressure controllers then? Are we okay on pressure controls? Pressure controller. Something that's controlling the pressure, keeping it constant. Okay.
I'm sorry, I just have to ask. So let's say you've set an inhibitory time of 1.5 seconds.
Okay.
And all of a sudden something changed. Mucus plug. Will it continue to try to force?
Yes, it will. It will not respond to changes in compliance and resistance. It will continue to deliver that pressure at that level until the end of the inspiratory time. However, there are safeguards built into that. So if the patient coughs against it, yeah, they can generate a higher pressure than what is set, and that will terminate the breath at that point. But that's, again, that's outside the normal, what we're talking about. Okay, volume controller. Volume controller means that the volume remains constant regardless of changes in compliance, and pressure becomes a variable that will change. So as compliance falls, volume stays the same, but the pressure would end up going up because it's a stiffer lung. Now this is unique in the sense that when we talk about a volume controller, we're really talking about something where the volume is directly measured as it's being delivered. And really the only instances these are piston-based ventilators. Okay? So with a piston, it pulls the piston back, fills that chamber with gas, and it delivers that entirely. So the volume never changes on a breath-by-breath basis. Okay? It's a volume-oriented breath, but I'm going to take a little twist on this in a second. Okay? Okay? We really only can say that patients being volume controlled if they're on a piston-based ventilator, which, again, other than the home, is not going to be a common thing. Most of the patients we ventilate are really being flow controlled. It's semantics, and if you walk into the ICU and say, oh, this patient is on a flow controller, they'll look at you like you got a third head. If you really, really want to be honest, though, it's controlling the flow rate that's coming out of the ventilator and allowing that flow to continue for a certain inspiratory time. So if I had 60 liters per minute of flow, constant flow at 60 liters per minute for 1 second, how much volume would I have delivered?
1 liter.
1 liter. 60 liters per minute is 1 liter per second. My inspiratory time is 1 second, so therefore I've delivered 1. And that's how the ventilator computes this. So even though we're controlling flow, the volume is also fixed. It's also a volume-oriented breath. But in the ICU, really, those ventilators, all 3 of those ones that we learned, or you guys were playing with, those are all really flow controllers.
They're not dual.
Well, they all, when they're in a volume-oriented mode, they are flow controller. When they are in the dual mode, that's a pressure-controlled breath.
Okay.
Because the pressure is fixed for that duration of that breath.
Okay. Right.
You said dual mode is usually pressure control?
Dual mode, the mandatory breath utilized in a dual mode is a pressure-based breath. It's a pressure-controlled breath.
Unless it's specified, that's fine.
You can do it. You can set any of those ventilators up in any one of these. Well, I shouldn't say that. In either of those, either as a flow controller or as a pressure controller. The software allows that.
So flow and volume are kind of the same?
Flow and volume are both volume-oriented breaths, yes. Because they both kind of have the same inherent characteristics. Flow is volume per unit time. Yes, Sue.
They are like, then technically they are same, then like, why separate mode? Like, if you
Because there is technically a difference. And I'm just being very picky about the words that I utilize to say this. Okay? They're both volume-oriented breaths, flow controllers and volume controllers. But there technically is a difference.
can we like, have it in a lab to see like?
I can show you a piston-based ventilator, sure. Or a bellows-based ventilater. The MA1. You won't see anything different. I mean, they all deliver gas to the patient, but how it's delivered is different. The last one is a time controller, and we're really just controlling inspiratory and expiratory times. And for right now, we're not going to encounter them at all. High-frequency ventilation is an example of this, but I'm not even touching that one. Mary can touch it. Now, let me go back and just summarize this. Pressure controller, changes in compliance, changes in resistance, what changes? Tidal volume and flow rate. Okay? Volume controller. Volume remains constant, pressure remains. The pressure changes with changes in compliance and resistance. Flow controller, same thing. Okay?
Same thing.
Same thing as volume controller. Time controller is weird because volume and pressure can change. Nothing makes sense.
So with flow control, pressure is there.
Yep. And this is a little algorithm you can go through. I don't think you'll ever utilize it, so let's just go on from there. It's in the book. And this is what I kind of have just been saying. You have volume-oriented ventilation or pressure-oriented ventilation. Okay. So far, so good. Right? Okay. There are 4 phases for each breath. So I can say I have a pressure control breath that has something which starts the breath. We're going to call that a trigger. Something which goes on during the delivery of the breath. I'm going to call that a limit. And that's probably the hardest of the 4 to figure out. Something that's going to stop the breath. That's called a cycle. And something that occurs between breaths. And that's called the baseline. Sorry? We'll hold on to, and we'll take these apart one by one. Notice that I'm going from, there's a transition from expiration to inspiration. The time during inspiration, transition from inspiration to expiration, and the time during expiration. So I have my inspiratory, I have a transition from expiration to inspiration, the inspiratory phase, transition from inspiration to expiration, in the expiratory phase. Something's starting the breath, something's going on during the breath, something's ending the breath, and then finally something's happening between breaths. That seems like a lot of BS, doesn't it? No, it makes a difference though. Because we're going to talk about how a pressure support breath ends is different than a pressure control breath. Okay? They're both pressure-oriented breaths, but they differ on what ends them. All right, so those 4 terms, trigger, limit, cycle, and baseline, and I will guarantee you limit will be the one that will go, huh? So let's talk about them individually. Trigger variable. This is what starts the breath. You may have heard this as being sensitivity.
Yes.
It's on the left side of the bird, right?
The vacuum.
There are many things that can turn on a breath. Actually, there's not many. Well, yeah, there is many, truly. We're going to focus really on just 4 things. First one is time. I can set up that bird to turn on by itself. There's a timer on it, right? I can set a backup rate on a ventilator. Set the respiratory rate to 12. Every 5 seconds it'll fire. Doesn't need any patient to say, I want a breath now. It'll just go ahead and fire on its own. You can have it turned on by a patient effort where a pressure is being monitored, and when a threshold pressure change occurs, it turns the breath on. We call that pressure triggering. What a novel idea. That's the way the bird triggers on, right? Create a small inspiratory pressure, negative pressure, goes ahead and initiates that breath to happen. Similarly, we can generate a flow. Now the flow obviously is generated by its pressure change. That's the only way flow can happen. But instead of monitoring airway pressure and using that as the trigger variable, I'm going to use airflow. Something we're going to call flow sensitivity or flow trigger. Okay? And then the final way to trigger a breath is manually. Clinician triggered. On the bird, if you pulled that little red knob, or not the red knob, red stick on the side, the breath would start. Same thing here. All the ventilators have a little button that says manual breath. You push the, starts the breath. So those are all triggers. Now there's other ways that you can look at it. Chest wall impedance, You know, putting sensors on the chest to sense when the chest wall is being moved. There's ones where you have a special catheter that's placed down in the esophagus and is looking for changes in intrapleural pressure and using that as a trigger. All kind of different ways to do it. Let's stick with the easy ones. All right. So far, so good? Let's turn the breath on. Time trigger is pretty obvious. I have a respiratory rate of 10. It's going to fire every 6 seconds. So we tell that one. Pressure sensitivity, just like on the bird, we're just going to say a few centimeters of water, 2 to 3 centimeters of water is typically the normal sensitivity you would set, and you turn the breath on. Now, that pressure sensitivity is referenced to the baseline pressure. So in other words, as I add 5 of PEEP, the pressure sensitivity will trigger at 3 if I have it set to -2. Does that make sense? If I add 5 of PEEP, do I want it to turn on when it goes to -2? No, because then I got to draw through the 5 plus the -2. I don't want to have 7 centimeters of water. That's crazy. So what the ventilator does is it says, okay, that sensitivity will always be referenced to the baseline pressure. If I add 5 of PEEP, they have to draw 2 below that 5 of PEEP or to a +3 to turn the ventilator on. Better?
You don't have to change that when you change the PEEP.
Very good. You don't. You set PEEP, you have a sensitivity set, the ventilator automatically knows that that's what it's supposed to do. Now, that's true of our ICU ventilators. You go to if you go to camp, they have external PEEP valves that they add onto the circuitry. Ventilator has no idea that it's there. So you have to adjust the sensitivity to compensate for it. Yes?
So is this is an initial setting, or is just an example we are showing for the PEEP? Because generally it's 3 to 5, right, the PEEP.
Okay.
No, I'm just asking, like,
Yeah.
do you go beyond, like, this +5? Like, can you go by +8, or is just the...
Can I have 8 of PEEP?
Yeah.
Sure. You have 20 of PEEP.
So, but it will always be...
But it'll always be referenced to that value. If I have a trigger of -2 and I put them on 20 of PEEP, at positive 18, it'll turn itself on.
And then sensitive, it goes to -5, then you can write it 20. Or sensitive is always set at -2.
Sensitivity is -2 to -3.
That's
Yeah, yeah. You don't want to become more insensitive,
Yeah.
which is this is a tricky one. An increased sensitivity means it's easier to turn on.
less than...
So -1 is a increased sensitivity when compared to -2. Semantics on this suck. I know, not just on this, but pretty much everything. A decreased sensitivity means you're making it harder for them to breathe. Okay. I'm assuming that's the way Mary covered it. Yeah, okay, so I'm not saying new. So again, graphically, what we'd be looking at, this is the inspiratory limb. This is the expiratory limb. At rest, there's 0 pressure in there. When they create -2, -3, whatever you have the sensitivity setting set for, it then will go ahead and recognize the patient wants a breath, and the ventilator will turn on and deliver the breath. Ba-ding! Trigger the breath on. Okay. What we would see graphically is you would see that pressure drop. And immediately, the ventilator should respond by delivering the breath. This is called an assisted breath. It's assisted because the patient triggered it on.
That's how you get the little negative piece.
That's what the little negative by the A is, yes. That means it's an assist. Yeah.
I thought assisted also meant that the patient triggers it on, but the ventilator stops it.
I haven't all the time I was talking about is turning it on. You are correct. But all I'm talking about is turning it on. Next way. This is flow triggering. Okay. The idea here being that the patient has to generate a small flow within the circuitry. The ventilator recognizes that flow has been depleted and turns on. You can skip pretty much everything on that slide because it's reference talking about the 7200. We're not even going to go there. Option 50. What the hell is option 50? Don't worry about it. Okay? All I want you to know is that you're going to have a sensitivity flow of about 3. Pressure 2 to 3, flow 3. Okay, sounds good. Next case.
Millimeters of water.
Liters per minute. So, you guys got this picture, right?
Yes.
Okay. Here's the way the ventilator knows that someone is trying to take a breath. Pressure's pretty easy because it can sense a drop in pressure. A flow is a little bit trickier. How do I know that a patient is beginning to generate some flow? The way it happens is in between breaths, the ventilator is putting out a flow of gas that's going around in a circle. It's being put out by the ventilator, and it's being read back by the expiratory flow sensor, and it's basically saying that whatever delivered flow I have is equal to whatever's being returned. I'm putting out a base flow of, say, 5 liters per minute, and I'm looking for that 5 liters per minute to come back on the expiratory limb. So far, so good? So if I don't see anything going on, then the patient's just sitting there. What if the patient now begins to try to take a breath in? That means that some of that flow that was coming out was taken by the patient and it's not being seen coming back. So in other words, the return flow is now less than what the ventilator put out. The ventilator says, holy shit, somebody must be wanting a breath. I'm going to deliver a breath. And that's the triggering mechanism. It sees a flow difference. Pardon me? Yep.
So it kind of goes in line with the sensitivity as the patient is initiating or assisting, doing the assist, it's generating the flow for the breath.
Instead of using pressure as the criterion, I'm using a change in flow. Couple of things of why this is important. First of all, this is the way we trigger most breaths. We don't use pressure trigger. We typically use flow trigger. The reason being is that patients, especially patients with COPD, can generate flow without generating large pressure changes. So they can generate a flow significant enough to trigger the vent even though the pressure drop isn't there. Trust me on that. The flow sensitivity is a little bit more sensitive. It is. I have no other way to put that. Okay. Downside to it. What if we have a cuff leak? It's going to keep on triggering all by its lonely self. In the face of leaks, flow triggering can be problematic. And I've seen patients self-cycle. Or, excuse me, I've seen, hold on, I'll tell you a story.
And a certain amount of flow that has to be missing for it to trigger a breath. Correct?
Yes, that's why I said the flow trigger was 3 liters per minute. Okay. So if it senses that 3 liters, let's use an example here. I put out 5, I see 5 coming back, nothing's happening. I put out 5, I see 2 coming back, 3 have been depleted, trigger the breath on. The minute it recognizes that only 2 are coming back.
But it could be either a leak or a patient.
Potentially, yeah, you could have a leak in the system. Throw another monkey wrench in there. How about if I put a nebulizer in the circuitry and I'm adding flow to the circuit? Now I'm really playing jack because I'm tricking it into never triggering. Clinically, it makes a difference. Okay. Don't worry about this when this was talking about flow by in a nebulizer. Technically, when you would turn the nebulizer on, it knew, or it automatically turned off flow by, but we're not going to talk about this. Go ahead. There's not, but there's a way that I can learn you how to do it. Using graphics, I can determine how much leak I have, and I can set my flow sensitivity more insensitive to account for that leak. Yes, there is a way to do it. Yes.
I don't know if it's right or wrong, but the delivered flow is equal to the return flow, right? And you said nothing happens.
Right. The ventilator doesn't trigger.
Then how the patient is how is he breathing on?
The patient isn't. That's this period before the next breath starts, where there's no flow. During your inspiratory and expiratory phases, is there a point in time where you're in the expiratory phase, but you're not moving gas? Yeah, you got a 1 to 2 ratio, right? Some of that part of that 2 portion, you're not doing anything.
So that is that portion.
That's that portion. That's the one on the left. Yeah.
You can use this when a patient can't. You said there was a brain dead patient that without one of these, they can't initiate a breath at all or a pressure change.
Yeah, right.
So how is it triggering if they're not?
They had a leak.
Well, even if it didn't have a leak, why do they have a brain dead on a machine that won't work unless you?
Well, they had a backup rate.
Okay.
Yeah. I mean, in between the time that you're not declared brain dead and we take you off, there's a period of time where all the testing is done. And it was during that time that the neurologist actually said, why is this ventilator at a higher rate than what it's set? Oops. Yeah.
So are you controlling flow on this? Like if you had to give them 15 liters,
Not
you
even-
had to read that, or?
I'm just talking about triggering. The example I gave was if I added a nebulizer in line and I was running it off the wall, then there would be other issues there. But I'm not going to touch that one right now. I would never ask you a question about it. Everybody got the concept of how this works. Go ahead, Holly.
Going beyond the trigger kind of, but when it's triggering to give a breath, is it trying to compensate for the lack of breath that's coming back?
No. It just recognizes that the patient wants something and it's turning the ventilator on to begin the inspiratory phase. Remember, this is the transition from exhalation to inhalation. Something's got to turn it on. And at this point it says, oh, I see if some flow has been gone. That must mean a patient wants some. Here's the breath. This is a real tough one. Someone stands at the bedside and pushes the manual breath. Pushes the manual breath. Pushes the manual breath. Pretty simple trigger mechanism. All right, that's triggering. Now let's talk about limiting. Some parameter is limited during the course of the breath. Limit variable remains constant through that phase, but doesn't end the breath. So it rises to a particular thing that you dial in and stays there until the breath ends.
But it doesn't end the breath.
But doesn't end the breath. So let's say I had a pressure-limited breath. That would mean that the pressure rises to a target pressure, stays there until something else turns it off. Here's a clue, guys. Whatever the control variable is typically the limit variable. Okay? Rises to that variable rises to that target, stays there until the breath, something else turns off the breath. And usually is if I have a flow controller, flow is what is being limited. If I have a pressure controller, pressure is what is being limited. And those are really only two that we end up using in the ICU. So. If what I'm saying is if I am using a flow controller, if flow is being controlled, flow is also being limited. In other words, I set a peak flow setting, and that peak flow is attained. I go to my peak flow setting, but I stay there till the end of the breath. But something other than flow is ending the breath. Yes?
So you're saying it's controlled, but it's also limited by what you are controlling it at?
Yes.
Okay.
And what is that something else with the no end?
Well, that's not limiting.
No, but like what could be that? Like what do you call that? With a
Cycle. What is turning it off? Okay. And a lot of people, including me, have and I catch myself because I'll say it's the ventilator's auto cycling. No, the ventilator's auto triggering. Cycling means ending the breath, not starting it. Okay, so I just said it 5 minutes ago. Okay, guy, just gotta be careful. Catch myself. That parameter with which some criterion is met turns it off. So it could be time cycled. My breath ends because a certain amount of time has elapsed. Pressure control ventilation means that I rise to a target pressure, that's the limiting value, and I stay there until something else turns it off, and that cycle variable is time. I can be pressure cycled, IPPB. I rise to my target pressure, ventilator shuts off. Volume cycled, when a preset volume has been delivered. Okay? And flow cycled, when a certain flow criterion has been reached. And these will all make a little more sense when we start talking about the different breath types. Because it's going to make a difference. And then finally, the baseline, that's pretty obvious. Whatever is going on during the expiratory phase. Now, technically, this was the question that Kim was asking before class. There is a period of time during both the inspiratory phase and the expiratory phase where gas is moving and possibly where there's no gas flow. So when I do an inspiratory plateau measurement, I have a flow of gas in to get to the peak pressure. I then pause the breath and allow for a plateau to be measured. That's a pause time. So I have an inspiratory flow and an inspiratory pause. Then I have the patient exhale, an expiratory flow, gas is moving, and there's a period of time before the start of the next breath. If I have 12 breaths per minute, that's 5 seconds for a total cycle time. I'm using 1 second for inspiration. It's not taking 4 seconds for them to totally exhale. It might take them another second and a half to exhale. The rest of the time is just waiting for the next breath, an expiratory pause. Baseline pressure is what we normally, what is normally reported? PEEP, ZEEP, technically MEEP. Expiratory retard, we don't use that anymore. Expiratory resistance. Remember on those COPD patients, what do we do? What do we teach them to breathe? pursed lip breathing, so we had an expiratory resistance they were breathing against. Brilliant! Brilliant! Let's add that to our ventilator. Let's make it harder for them to exit. Kind of a stupid thing. So, we don't use it anymore, but technically it's there. So here's our transition from inspiration to expiration. That's our trigger. Our inspiratory time, our expiratory flow, and our expiratory pause.
When you're on a ventilator, you're never nose breathing, are you?
You're never who?
Nose breathing.
No, you have an endotracheal or tracheal ostomy tube in. Now, I will tell you, if you watch people and they're in respiratory stress, they will have nasal flaring, even though, go figure. Oh my God.
That's for reference only, right? Cool.
It's reference only. It's there. So those are our 4 primary variables: trigger, limit, cycle, and baseline. There's also some conditional variables, meaning if then. Okay. There's some breaths which are called sigh breaths. If 300 breaths have elapsed, then give a sigh. If 10 minutes has gone by, then give a sigh. If the patient is apneic, then begin apnea ventilation. Okay. If the patient has not triggered and the amount of time between breaths has elapsed, then give a breath. Okay? So they're just conditionals based upon certain situations. And the last part dealing with this is basically that as this ventilator is blowing gas, there is some output that is created, and we can graphically depict that. And on page 32 of the lab manual, 32? Does that sound right? That doesn't sound right. It's not 32. It's much further than that. This is back when I put the airway stuff in, which takes up a ton. Not that manual. My lab manual. So, just listen to me for a second. For a pressure control breath, there is a unique pressure, flow, and volume characteristics that are created. For a flow-controlled, volume-oriented breath, there is a certain pressure, flow, and volume pattern that is created. And it's a given. Okay.
Page 140.
140?
Yeah.
Actually, 141 is what I was really wanting to look at. You can see there's 5 different breath types. And I can look, just by looking at the first one, I can say what type of breath that is. It is a pressure-controlled breath. This is a rectilinear rise to pressure in B, which means that I have a square wave flow pattern. So certain characteristics are going to generate certain outputs. Might not make a whole lot of sense yet, but as we get more into waveforms, it'll make a little more sense. Maybe not, I don't know. Lots of alarms are there, and let's do a quick little review before. I don't have anything here, but power? How's it powered? What's triggering? Something that starts the breath. Limiting? No.
This side of the
control.
It's inside the breath, but it's the variable that remains constant or rises to a target, better way to put it, but it doesn't end the breath. Cycling? That's what ends the breath. Baseline? What happens during exhalation. Okay. All right, let me just do Module H. It's not a very long one. Is it? But this is chapter... But there's not a lot of... I didn't think there was a lot of slides for this. Okay. So this is chapter 4. And because you're nice, we'll do a video.
This is something. There was a fire at a house in San Diego, and when they got there, the firefighters stumbled upon a marijuana farm inside a converted garage. And they think the fire was started because people there were tampering with the wiring to accommodate. You need a lot of energy to grow a pot. Here's the story from the local news.
Carelessness and cannabis triggered a house fire in San Diego. When firefighters put out the flames, they discovered an elaborate pot growing operation there in the garage. Firefighters say some of those marijuana plants did burn, but they also say one person was treated for smoke inhalation.
So much smoke.
Okay. Again, our goals of what we're trying to accomplish by mechanically ventilating are pretty simple. I want to create an alveolar minute ventilation that is sufficient enough to remove carbon dioxide and keep pH in a normal range. I also want to provide tissue oxygenation. Secondarily, or along with that, should come relief of any dyspnea the patient has, as well as giving the muscles some time to recoup. Okay? Those foolish people who run will tell you that as you exercise and you don't keep running until you can't run anymore and your legs fall off. You need periods to rest, to recuperate. Classic indications for mechanical ventilation, I believe Egan calls the respiratory failure type 1 and type 2, where type 1 is hypercapnic and type 2 is hypoxemic. So basically a failure to oxygenate or a failure to ventilate. Apnea is pretty obvious. If you're apneic, that's not your mother-in-law, you probably want to ventilate them.
You don't like your mother-in-law, do you?
You say that. Now notice I also have on here impending respiratory failure. Do I have to wait until, if it's pretty obvious that they're going to be going down the tubes, you can intubate and mechanically ventilate them before that time happens. Okay? Traumas are a classic example. We know they're going to need to be ventilated at some point, so why delay it? Yes? All I'm saying is mechanical ventilation. They didn't say if it was invasive or non-invasive. Yep. Now, there are certain patients that non-invasive is inappropriate for. Right. Okay. And this is basically what ends up happening. Kind of what I just said. And here we go again. I just said this. See, a lot of these are needed. Sometimes the alveolar minute ventilation, and we talked about the neuromuscular disease and the drug overdose, kind of classic ones. Ventilatory failure usually occurs because of either a compliance or a resistance issue. And then again, that hypoxemic is just, the hypoxemia is so refractory that conventional mechanisms of raising the oxygen just aren't working. So here's a patient who needs to be intubated and mechanically ventilated. Okay, hypercarbic, hypoxemic, worst of both worlds. Here's a chronic patient. Again, just because the PCO2 is 60 doesn't mean we're going to intubate and ventilate this patient. Common sense. Oh, my friend, the acute on chronic. It's not stupid. Okay. This would imply that their normal PCO2 is probably about 55, but because of the hypoxemia, they're hyperventilating from their normal. So I end up what looks like a metabolic alkalemia, right?
Yes.
Whenever you see that, really stop and think about, that's probably a COPD patient.
See what?
Pardon me?
See what? Normally I'm pretty good at that.
Whenever I see a metabolic alkalemia,
Oh,
they're a rare breed.
okay.
They probably aren't acute on chronic.
So that what we see the least likely is metabolic alkalosis.
Yeah, I would say it's probably true. So here's again that case where we need to mechanically ventilate them. Here's a hypoxemic respiratory failure. Ventilating okay, but they're not exchanging gases, at least as far as PO2 is concerned. And when we start to get to higher and higher FiO2s, despite not having a good PO2, probably should look at, we may need to intubate and mechanically ventilate, yes.
You have an acute on chronic condition, and you see that what appears to be a metabolic cirrhosis. How long do you wait before you repeat the ABG to see if
Depends what I'm doing between time. What does this patient need? How would you treat that blood gas?
That's the last one.
This one right here. Give him some oxygen. Yeah. That's easy. I can use a pulse oximeter to be able to monitor them and evaluate them. So as long as I'm seeing the PO2 come up, but I want to make sure that I don't go too aggressive.
let's say there's no like a set minimum time or a
No.
set maximum?
Well, as far as how long you wait on that to get it,
Before you
yeah, we typically wait 30 minutes.
Oh, that's it.
Yeah. It's usually enough time for whatever changed, especially mechanically ventilated patients. 30 minutes is enough time typically to... All right. And that respiratory insufficiency was, again, that point in time where they're not there yet, but they're going to be very soon in a spot where we need to intubate them.
And how can you find this one?
The patient's blood gas looks okay, but they look like crap.
Are you talking about
They-
the chronic ventilator failure one?
No, I'm talking about respiratory insufficiency. I'm talking about a condition where somebody is breathing at 35 times a minute, they're using accessory muscles, they're cyanotic, but their blood gases really don't look that bad. They're working like hell to get to that not so bad looking blood gas. How long are you going to keep that up?
Until they get tired.
Until they get tired, and that's not going to be a very long time. Yes, sir.
Well, hypocapnic respiratory failure, you said you can ventilate or no?
If it's acute, yeah. Yeah, this person here needs to be ventilated, sure. And this is kind of what the blood gas looks like. Yeah.
The respiratory insufficiency, would that be like someone that's having asthma attack?
Could be. Could be. That transitional period in between. We're going from that respiratory alkalosis to the respiratory acidosis, but been transitioning through, you get a normal blood gas. That's why we don't use blood gases as an index of how to treat asthmatics. Poor index. Okay. So what we'll do now is stop the recording.